And I see some new people are joining us. So hello and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Importantly, everything we do is in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with and impacted by PD. Not everyone with Parkinson's will experience psychosis, but it can be frightening if you don't know what's happening or how to handle it. It is important to be able to recognize these symptoms if they occur. Today, we will learn what to watch for and how to respond to these behavior changes that may ensure the safety and well-being of you and your loved one. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day. The Parkinson's Foundation provides weekly education and wellness programs virtually through our PD Health at Home series, which includes Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, our expert briefings, and our Spanish language programming, Y Salud en Casa. Join us for next week's webinar on Parkinsonisms. Parkinsonism is a term used to describe a collection of movement symptoms associated with several conditions, including Parkinson's disease. Learn about the types of Parkinsonisms and how they are diagnosed and treated. You can find out more and register for our PD Health at Home programs at parkinson.org/pdhealth. To begin our formal presentation, I'd like to introduce our first presenter for today's webinar. Dr. Heshan Fernando is a clinical neuropsychologist specializing in comprehensive neuropsychological evaluations for individuals with known or suspected disorders of the central nervous system. Dr. Fernando earned his master's degree in psychology from New York University and his doctorate in clinical psychology from Long Island University in Brooklyn. He completed his pre-doctoral internship and his postdoctoral fellowship in clinical neuropsychology at University of Florida Health Science Center in Gainesville. Dr. Fernando is a member of the American Academy of Clinical Neuropsychology and the International Neuropsychological Society. His clinical interests include dementia, movement disorders, and atypical Parkinsonian syndromes, along with providing compassionate clinical care and treatment recommendations for patients and their families. Dr. Fernando, thanks so much for joining us today.
Thank you for having me. A pleasure to join you, everyone, and a pleasure to serve you today. I really appreciate this opportunity to speak on a very important topic. And so without further ado, let's go ahead and get started. I will share my screen here. Okay, hopefully everyone can see that.
Yep, looks great.
Great. All right, so just want to start off by telling you folks that in terms of disclosures, I've previously served as an educational content reviewer for the Parkinson's Foundation and received a small remuneration as part of my role. Otherwise, I don't have any other disclosures or financial relationships with outside or non-healthcare entities. And I am here today just because I love being with you all. Okay. So we're going to cover a few different topics today, and I'm going to cover the first two learning objectives. One really revolves around what is PD or Parkinson's disease psychosis, okay? How do we recognize that? What are some of the symptoms? What are some of the important topics and nomenclature that we need to be aware of in discussing PD psychosis? And then more importantly, how do we respond to this when we see this in our loved ones, family members, and friends? Okay. So what is PD psychosis? Well, first of all, it's what we consider to be a non-motor symptom of Parkinson's disease. And there are several non-motor symptoms, when we think about loss of smell and taste, dizziness upon standing, which we call orthostasis, sometimes temperature dysregulation, constipation. These are all considered to be non-motor features of Parkinson's. And so these are very important topics to discuss in their own right, because typically we often focus on just the motor aspects of Parkinson's. PD psychosis is one of those non-motor features, and what we consider this is a kind of a break or loss of touch with reality, right? That often manifests as hallucinations, something we call illusions, and then delusions or confusion. Okay, I'll actually kind of expound on this a little bit more and talk about what these terms are and what they exactly mean. But in terms of prevalence rates, we generally recognize that about maybe 50% or more of patients with Parkinson's disease will eventually develop these symptoms over the disease course. And, it really depends on which research you're referencing, but, some studies say 20 to 40%, some say 50%, some say 70% in kind of more of the advanced disease stages, and that difference in variance prevalence rates really reflects just an evolving definition of PD psychosis. So initially, when we talked about PD psychosis in the field, it was really kind of more of those well-formed, clear-cut visual hallucinations that are happening throughout the day. And now we've really kind of expanded that to really include some of the more minor or less apparent symptoms, such as shadows in the visual periphery, or just kind of this presence hallucinations where we feel like something is around us, but it's not. Regardless, what we do know is that that rate of PD psychosis increases with age and disease progression. That seems to be clearly delineated in the research literature, and we'll talk about that a little bit more. Now, again, a few basic definitions. When we talk about hallucinations, we're talking about things that essentially appeal to one of the five senses, right? Typically, we talk about things that you see or hear or smell or taste or even feel that is actually not there, okay? Now, I think the guiding rule is that 80% of these hallucinations associated with PD psychosis are visual in nature. And then roughly about 15% or so are auditory hallucinations. And then the remaining percentage really focuses on what we call gustatory or taste, olfactory hallucinations, which revolve around smell, and then tactile hallucinations, which is kind of a feeling, an actual tactile feeling that something is there, but it's actually not. Okay. Now, one thing I would kind of add to this is that when we first started to really kind of explore this concept of visual hallucinations associated with PD psychosis, there was maybe this misassumption that if you had auditory hallucinations, this was more kind of a psychiatric phenomenon. It's not really anything having to do with Parkinson's or Lewy body dementia, which is kind of a cousin of Parkinson's disease. And that is really not true. So I think that's something that I like patients and loved ones to be aware of, because it can really kind of manifest in a number of ways, even though predominantly it manifests as visual hallucinations. There's also a concept we call illusions. Now, this is really to highlight things that occur where there's a misperception of an actual real object in the environmental space. So sometimes people might look at a hat and think it's a small animal like a dog. Sometimes, patients might look at a coat rack and then misperceive that as an actual person. But the differentiating marker here is that this is an actual real object that's misperceived. And then finally, we have delusions, which are these kind of false fixed beliefs that typically revolve around feelings of jealousy. So maybe a spouse being unfaithful. Sometimes they're persecutory in nature, like somebody's coming after me or the government is coming after me. And sometimes they're what we call somatic. And this really relates to body functioning, physical appearance, something having to do with the body. And really, the guiding principle of delusions is you don't really need to have anything appear in your environment for those delusions to manifest. And typically, we see these types of psychotic symptoms in the later stages of Parkinson's disease. Now, this is a graph that really kind of helps capture what Parkinson's disease psychosis looks like over the course of time. So as you can see on the left side of that graph, very little is going on, a lot of white. And most of the features that we see early, preclinical stages revolve around those non-motor symptoms. So again, that's the loss of smell and taste, and then some of those GI stomach-related symptoms. So constipation being kind of the core feature before actual motor symptoms develop. As we look towards the right side of that graph, we can see that over time, from 0 to 20 years, we see some of those non-motor features pick up in intensity and frequency. We see those motor symptoms also manifest over time. And then as we advance into the more later stages of Parkinson's disease, we see some of those complicating factors like PD psychosis. Okay. This is another kind of depiction of what PD psychosis looks like, across the various stages. And so some of you may be familiar with this clinical tool, but if you've met with your neurologist, they'll often assign you something called a UPDRS score. We do that for your motor symptoms. We do that for various activity levels and things like that. But more importantly, we also capture non-motor symptoms. And so we typically conceptualize PD psychosis across 4 different stages, where in the initial first stage, we might see something like passage hallucinations. These are kind of those shadows in the visual periphery. Sometimes it's a kind of a quick shadow that just kind of moves away or disappears. Sometimes it's just the feeling that something is there around you, and when you look to see, it's not, right? And as we progress into the later stages, we start to see more clear-cut visual hallucinations that appear centrally in our vision. There is insight into that, knowing that, look, I'm seeing something here, but I know it's not real. And as the disease progresses again, we see those clear-cut visual hallucinations, but perhaps without that insight, and we start to see patients interact with those hallucinations, whether they're auditory or visual or whatnot. And then finally, in that fourth stage, we typically see delusions being a part of that experience. Now, I will say, having seen many, many patients with Parkinson's disease dementia, and even Lewy body dementia, it's generally, in my experience, a rare phenomenon to see some of those delusional beliefs manifest. Now, what are some of the causes of Parkinson's disease psychosis? Well, I think the number one thing that people should take away as far as causes go is medications. Generally speaking, medications are the culprit underlying PD psychosis. And so 3 areas that I ask folks to look at in conjunction with their physician is to look at dopaminergic medication. So this is like Sinemet, right? Or carbidopa, levodopa, where a little bit too much of that medication is in the system, and so it's resulting in manifesting in PD psychosis. There are also medications called dopamine agonists, okay? Now, the end result is the same as those dopamine medications like Sinemet, but they work a little bit differently chemically, in the sense that they just stimulate the natural production of dopamine in your body and keep it in your system a little bit longer. So these are medications like Mirapex or Requip, and a little bit too much of that in the system can also result in PD psychosis. It doesn't have to be a Parkinson's related medication, however, to also result in PD psychosis. Sometimes there's these non-dopaminergic medications, even things as fairly benign as Advil or Tylenol. Sometimes just the addition of any kind of new medication into the system is just enough to cause some of those psychotic symptoms. Medications that particularly have cognitive side effects, like what we call anticholinergic medications, these are probably the best known entities that are responsible for causing cognitive dysfunction and PD psychosis. So where I ask folks to really be on the lookout for is medications like sleep aids. So Advil PM, Tylenol PM, Benadryl, Unisom. They all have this chemical called diphenhydramine, and so they essentially are variants of Benadryl, okay? And they're well known for having caused not only cognitive dysfunction in older adults, but then also in terms of stimulating some of these PD psychosis symptoms. Other medications like oxybutynin for bladder control or Paxil for mood, they also have these anticholinergic effects. And so a careful review of some of these non-Parkinson's medications with your physician is really critical. Okay. Now, aside from medications, we do know that patients with cognitive impairment or even dementia, these folks are also more vulnerable to PD psychosis. We know that Parkinson's disease and its multiple variants affect things like your basic attention and sustained attention, your recent memory, and then executive functions, which is kind of those CEO skills of your brain that do multitasking and problem solving, planning, and organizing. But we also know that it affects your visual, spatial, and perceptual skills as well, and even your constructional skills. So translating what you see into like written material drawings, right? Those skills tend to decline over time. And I'm going to show you something that I think will be really interesting from a patient standpoint and really help folks understand what happens when you see some of these skills decline. So stay tuned for that. Now, the last thing is delirium. So this is a standalone medical condition. It's an acute condition that can result in altered mental status, disorganized thinking or confusion, and even visual hallucinations. I say standalone because it can happen for a number of reasons, like urinary tract infections or dehydration, other medical conditions like liver dysfunction or kidney dysfunction, even chemical imbalances in your electrolytes like sodium and potassium. And some of those medications, of course, that I mentioned, those anticholinergic medications, pain medications, benzos, all of these have the potential to result in delirium itself, but then folks who have Parkinson's disease are even more prone to these PD psychosis symptoms via delirium. And so that's another thing to be kind of aware of. Is this a reversible condition, right? Because if it is, treating that offending medical variable, if you will often bring things back to where they were before. Now, a lot of what I've talked about really revolves around that neurotransmitter dopamine. But what we've seen in the more recent studies is that serotonin is also involved in PD psychosis. And this has actually birthed some new medications to treat PD psychosis, which I'll get to in a bit. But what we've seen in the research is that increases in serotonin in the brain can also result in PD psychosis. And some studies have really looked at what we call this upregulation or increased firing of those networks and brain cells that are in the visual processing systems of the brain, the back of the brain. And so that increased firing of neurons in the brain can sometimes generate visual hallucinations or illusions. And so really kind of looking at multiple neurotransmitters from both a research and clinical standpoint is really critical for not only better understanding PD psychosis, but then knowing how do we treat this, right? So dopamine, serotonin, acetylcholine, norepinephrine, these are all considered to be key neurotransmitters that are involved with chemical imbalance and can potentially result in PD psychosis. Now, coming back to that visual skills impairment that I was mentioning. So we know that the visual pathway of the brain is a very complex one. It begins at the eyes and extends all the way back to the brain, stops at a few network hubs as well. And there's this, very complex interpretation of visual information that normally gets translated to, what we see. So what you see is what you get, right? But when there's disruption of that visual pathway, we know that that sensory input, beginning at the eyes and extending all the way to the cortex of the brain, the back of the brain, something goes awry, and this can sometimes result in hallucinations or visual misperceptions. We also know that actual vision-related impairments can even exacerbate some of these visual, spatial, and perceptual difficulties. So things like cataracts or macular degeneration, um, diplopia, which is essentially double vision, or even abnormalities in the way we maintain gaze and move our eyes. Are they moving together, or even the eyelids closing prematurely when we don't want it to? All of those can really exacerbate some of those visual sensory difficulties and result in PD psychosis. But this is an actual patient example of a patient with Parkinson's disease dementia. And I apologize about the noise out there. So this is actual a patient with Parkinson's disease dementia, relatively early in the disease course. And you can see from looking, comparing this example to the prior one that I just showed you, the actual stimulus, it kind of looks like the figure that we saw, but there's a little bit of planning and organization issues that kind of got in the way. And, we can clearly see that while that figure is generally appreciated, there's some things that are going awry here, right? Now, this is another patient with Parkinson's disease dementia, and this is far more advanced. Um, this is far more advanced in the disease course, and to me, I can probably appreciate this because I work with this particular test all the time. But anyone else might look at this and say, like, "Gosh, I don't really know what's happening here," right? But there's significant not only executive skills deficits, but individual spatial deficits as well. Over here was a patient with Lewy body dementia. Now you can clearly see that there's marked distortion of that figure that I showed you earlier, even inversion of elements where things are essentially flipped around 180 degrees. And this patient was pretty far along in the disease course. Um, but I share all of that with you because, I think I want everyone to kind of have an appreciation of what can happen sometimes with our normal visual, spatial, and perceptual skills that can result in misinterpretation of the environment and leave us prone to various things like illusions or hallucinations, right? All of that is essentially founded upon a disruption of neurological networks involved in visual skills. Now, let's talk about a little bit about how do we treat PD psychosis, right? And so this is important for not only for patients, but then also caregivers and loved ones. There's really three steps I want to talk about. One is really kind of just consulting with your physician and looking for what other explanations might kind of explain why PD psychosis is manifesting in this patient so acutely, right? So first step is to really look for any kind of possible illness or alternative explanation. Oftentimes, again, as I mentioned before, this is a urinary tract infection. This is pneumonia or dehydration, something kind of medically complex, something's gone awry. And if we treat that medical condition, do we see the PD psychosis go away? And usually we do. Are there errors in current medication regimen? Now, I have to say, out of all the patients that I see in my field, I think the Parkinson's disease medication regimen is the most complex I've ever seen. With some of my patients taking, Cinnamon up to 8 times a day. Now, I take one medication in the morning, and I have to tell you, sometimes I forget. And so to take it 8 times a day at specific times, I just think that there's more vulnerability to medication errors. So sometimes that might be a missed dose or even a double dose of medications. And so that influence on dopamine and various other neurotransmitters in the brain as a result of that medication error can also result in PD psychosis. It's important to know that because, sometimes when we have PD psychosis and we go to our neurologist, the natural course of action is to kind of taper or change some of the medications. But if it's due to error, we need to know that first off. Finally, are there new medications that were recently added? So sometimes just the addition of any new medication, Parkinson's related or not, can be just enough to kind of tip that equilibrium off balance and result in these psychotic symptoms. So if we remove that medication or even change that medication, do we see these symptoms go away? After we do that critical kind of pre-review, if you will, then we start to look and focus specifically on Parkinson's medication. So eliminating any non-essential ones, like those anticholinergic medications, like maybe oxybutynin or Paxil, and maybe changing to a less offending drug. Amantadine, which is often prescribed for patients with Parkinson's to help control dyskinesias. So do we kind of take that medication offline, see if those symptoms go away? Other medications called MAOI inhibitors, MAOI-B inhibitors. These are all medications that serve a useful role in treating various symptoms, but are not considered essential at the moment. Then we look at kind of those primary Parkinson's medications like Sinemet or some of those dopamine agonists like Mirapex and Requip, and see if we reduce those medications, do we see some of these symptoms resolve? Now, let's say that medication regimen is optimized. There's really no room to reduce or change medications. You're on the best medication that for various symptoms. Well, then we look at actual medications that treat these PD psychotic symptoms, right? So two of the more common ones are clozapine and quetiapine, or Clozaril and Seroquel. These are medications that essentially help treat some of those symptoms, so you don't have to make any adjustments in some of the other medications. Nuplazid is one of those newer medications that focuses on serotonin specifically. So as you will remember, serotonin is kind of one of those newer areas of investigation. And so if we can reduce some of that high level serotonin activity, do we see some of these PD psychotic symptoms go away? And the beauty of it is we don't affect dopamine at all, and thereby we don't affect any kind of the movement motor symptoms. As a general rule, we try to avoid kind of these first generation antipsychotics like Haldol, because they unfortunately worsen some of those motor symptoms. This is kind of a depiction of this fine balancing act that we have to engage in when controlling not only Parkinson's motor symptoms like tremors, but then also minimizing any chance for PD psychosis. So as you can see, the better we are at controlling PD motor symptoms, we're not so good at controlling PD psychosis symptoms sometimes, and so we have to adjust those medications appropriately. Okay. Now, for folks who are responding to loved ones with PD psychosis, what do you do? Well, I want to focus on each one of those symptoms separately, but hallucinations, obviously consulting with your doctor, staying calm and patient with your loved one as you're in the moment, right? Being in a moment of crisis, it can be even more jarring for patients when they're having these visual hallucinations, but then the environment is also somewhat chaotic. More tangible things like increasing lighting at night. A lot of times, some of these visual hallucinations, particularly the ones coming in and out of sleep, they don't tend to happen if you have appropriate lighting. So obviously during the daytime, nice well-lit conditions. During nighttime, dark, sleep-friendly conditions, but maybe a night light or something, so that there is less opportunity for visual confusion. Talking to your loved ones about his or her experience, and just creating a network and environment of safety to discuss something that is really kind of jarring, but sometimes embarrassing and kind of shaming for patients, because they just don't know what's going on. This is very unusual, and they don't know if they can talk to somebody about this. And so creating that atmosphere where you're encouraging our patients to really kind of discuss these things openly at home really also helps when discussing these things in the evaluation room. In some cases, explaining that the experience is not real. So if the patient has insight, just saying to them, hey, I know you're seeing this, but it's actually not real. You're safe. You're okay. There's nothing to worry about. That can be really reassuring. for folks who don't have insight, I think it's rarely beneficial to argue or challenge those folks because, again, they don't have insight and it just feels very real, and there's nothing that can really challenge that. And so using tools like distraction, kind of going off to a different topic, or saying, if let's say somebody sees like a small animal, like, oh, don't worry, I'll take the dog outside. The dog won't bother you anymore. Those are good ways to kind of mitigate those challenging situations where there's reduced insight. Obviously, educating close friends and family so that they're also in a position to help, and this is not necessarily sitting solely on your shoulders as a caregiver. Similar concepts for delusions and confusion, obviously talking with your doctor, remaining calm and patient. The big thing here is because of those delusions, we want to make sure that there's no immediate danger in the environment. So guns are what I usually come to mind. So making sure that they're locked in the gun cabinet, keeping any dangerous objects like knives or something like that in secure locations. So if there is any kind of delusional symptoms, patients who often feel threatened won't feel the need to kind of grab something and react, right? On a more kind of benign, from a more benign stance, just arranging furniture in a way that, if there's any kind of delusions or visual hallucinations, we're kind of avoiding any kind of mishaps like falls, by making the environment a little bit more clear and um, uh, more patient friendly. Again, not challenging or arguing with the patient. That's just really not helpful. And then educating close family and friends. Similar concept with agitation and aggression. Again, remaining calm and patient is very critical here. Keeping dangerous objects in secure locations, keeping movements, to a minimum. Listening attentively, provide space, don't overcrowd, and then obviously calling 911 if safety is a concern. So, I think the one thing that I want you guys to kind of take away from this, and I've included some references here if you feel like reading, is that there's a lot that you can do from a caregiver standpoint to respond to not only recognize PD psychosis, but then respond to it appropriately. And that can really help guide not only your neurologist or other clinicians involved in care, as you go to outpatient doctor's visits, but it can also help you in very kind of acute crisis moments where you're maybe having to transition to the emergency room. And your information can really help doctors create an environment where they'll help patients recover quicker, right? Like appropriate lighting or a room with a window or something like that, right? Being armed with that knowledge is something that uh, not only will help you and the patient, but oftentimes help physicians and folks in the ED who maybe aren't aware of what this looks like and what to do about it. Krista, I think you're muted.
Yes, thank you. I was just thanking you for the way that you offered this information to myself and to our community here that felt easeful and understanding. I'll say a scary topic for many of us who might be experiencing this. So really appreciate the way that you addressed this topic so gently and informatively in a way that felt digestible to us all. And we'll see you back, Dr. Fernando, for a Q&A after we hear from Ruth. So as we move into how to communicate about psychosis, we welcome our second presenter, Ruth Maidens. Ruth completed a Bachelor of Science from the University of Alberta. She then continued her education as a firefighter at Texas A&M University, where she discovered her passion for healthcare. Back in Alberta, she completed and worked as a primary care paramedic. Now, Ruth is the health promotion facilitator at the Parkinson and Movement Disorder program at the University of Alberta with Alberta Health Services. She designs and facilitates programs for patients with PD, including the recently launched Thriving with Parkinson's Mindfulness Exercise and Education program. Ruth, thanks so much for joining us today.
Excellent. Thank you so much, Krista, for that introduction. I'll start sharing my screen here, as I also just want to say a big thank you to the Parkinson's Foundation for allowing me to speak today and inviting me. Um, it's not very common that my training in EMS and now my work in the world of Parkinson's line up so perfectly. So, thanks to the foundation for this opportunity. I hope everyone can see my screen here. Krista, let me know if you can't. Um, so I have nothing to disclose in regards to this presentation. However, I will just mention that most of my training in emergency departments does come from a Canadian perspective. So most departments do work very similarly, but not all things will apply in all departments. Um, so Dr. Fernando did an amazing presentation on these first two topics. Thank you so much. Such an informative presentation. So now I'm going to discuss a little bit about understanding how to communicate with when you're calling 911 and what to do before and when EMS arrives. So, as Dr. Fernando mentioned, a couple of those times when you want to seek reinforcements and you want to ask for help, when psychosis or hallucinations, especially those without that insight, can cause some behavioral changes. So it's very important, like Dr. Fernando mentioned, to talk about that with your neurologist, with the person that normally follows your Parkinson's disease. But when those behavioral changes become more acute, it's important to have those addressed. So, Parkinson's psychosis can sometimes cause other injuries. If, for say, you're have some hallucinations and you're trying to avoid something, that could cause some injuries, maybe a fall. It can also cause agitation and aggression in that individual experiencing psychosis. So, although the end goal to treat that psychosis may come from your neurologist, that healthcare team, by adjusting those PD medications, we need to focus and treat the acute problems right now that are causing a safety risk. So that is always our first concern, is the safety of the individual with Parkinson's as well as those around them. So, anytime that we have to call 911 when we're in an emergency can be very stressful. So, if there is one tip that I can give you to make that initial call to 911 go smoothly, it's to take a deep breath and to listen. As mundane as that sounds, it's actually very common for a caller to 911 to want to get as much information out as quickly as possible. And in reality, that can slow down the process. When we answer a call to 911, each call taker has a specific order of questions to answer, and that will help them get the right resources headed to your location even before you're done explaining everything. And so that can help the process move a lot quicker. Additionally, like we've mentioned, these scenarios can become very complicated. Parkinson's disease with disease psychosis, as well as potentially another injury, another cause for delirium, like Dr. Fernando mentioned, a UTI or things of that nature, can cause many layers into this problem. So, what I like to tell people to do is to focus on the main reason for calling and those few important bullet points. This is not the time to be giving the detailed explanations of the individual with Parkinson's history or medications at exactly what time they take them. We want to keep it nice and simple because all the information that you're relaying to the call taker then gets translated onto the computer, gets put through a dispatcher, and then to a crew through their own computer. So it kind of becomes like that children's game of telephone where the more people we add in, the more miscommunication we can end up with. So, in order for everyone to be on the same page, try to keep things as simple as possible, even though I understand it is a very complicated situation. So, okay, another thing that's very important when it comes to psychosis is that we answer questions honestly. It can be a very difficult conversation to have. Sometimes folks might be worried or embarrassed to recount certain behaviors, either of yourself with experiencing the Parkinson's psychosis or of a loved one. That especially when there's certain hallucinations or aggression or particular um, injuries. But I want to take this time to assure you that it is never EMS's goal to pass judgment. They are healthcare professionals, just like the rest of your healthcare professional team. And they are aware that this is a medical condition and just need all the proper information to be able to help you properly. For example, in Alberta, we have two different levels of ambulances, one with a basic life support and one with advanced life support. And if we don't disclose all the information to the call taker, you may end up getting a basic life support ambulance that doesn't have all the medications that a person with Parkinson's psychosis would require at that time. So, this is why it's just very important to disclose all that information. And finally, once you are on the phone with 911, you've given them all your information and they tell you that someone is on their way, don't hang up that phone immediately. Stay on the line with them until someone actually comes to your door or they tell you that you can hang up. So, in that time where you're waiting for them to arrive, there's a few things that I want you to keep in the back of your mind. So, again, safety is always our first priority. So, do what you need to do to keep everyone involved safe. So, if you are the individual with Parkinson's experiencing psychosis, um, that's a very distressing situation. You might need to do some things to relax. Try not to do anything too drastic that could cause injury. If you're the person, like a family member or a caretaker, this might mean that you need to take some space away from that person experiencing psychosis in order to stay safe. It might mean that you need to keep that individual away from other objects or things that could hurt them. And of course, if anything changes in that time, make sure you let the call taker know. Some other things that you can do before EMS arrives. One of the things that crews will likely ask you right away is for the individual's ID, their healthcare card or insurance card, and a list of current medications. So, if you can have those nearby on hand, that will make things run very smoothly and get help quickly once the crew arrives. These are just my two little notes from EMS. Please put your pets in another room. Sometimes the call taker will ask you to do this because, especially if some departments do have some protocols that crews can't enter if there are pets in the room. If it's dark outside, turn on those lights outside so that the crew can find your house nice and quickly. And if you have time, you can start to gather some of the items that you'll need for the hospital. I like to tell people to take at least 1 day's worth of medications with them. The Parkinson's Foundation has an amazing hospital safety kit. That's very important, and I'll talk about that in a minute, as well as any other government documents that you might need. In Alberta, here, we have a goals of care designation or a personal directive. And that just helps if there is any decisions that need to be made at the hospital. Those documents are already there and it can happen much quicker. So once EMS arrives, it's important to remember that every situation is a little bit different. So the person with Parkinson's, the any family members that are there, and the crew need to all work together to provide the best care possible. I like to remind people to try to let the person with Parkinson's disease answer as many questions as possible. Even if they're experiencing that psychosis, it's really easy for us to jump in and start answering all the questions. But by letting them answer as much as possible, the crew will really get a good sense of where they are at and what their truth is. We like to make sure that we're still respecting that the person experiencing psychosis, that is their reality. And so you're always welcome to give the crew maybe some corrections or lead them in a certain direction if not everything is 100% your reality, but we do like to make sure that they can gather that information. Another extremely important part of dealing with Parkinson's psychosis is that not all medications that we use to treat psychosis or psychosis symptoms is appropriate in Parkinson's disease. So that's where that Parkinson's Care Summary for Health Professionals that you can find in the Parkinson's Foundation Hospital Safety Guide can really come in handy. You can give that sheet right to the crew for them and for the hospital to use. That will let them know about medications that shouldn't be used. For Dr. Fernando mentioned a few. For example, a person with Parkinson's disease should not be given Haldol, and that is something that a lot of departments do carry on the ambulance. So I also added here that it's important to bring your medications when you go to the hospital in an ambulance. I often, in my experience, crews will tell you to not bring your medication because the hospital has many of them and you don't want to lose them, which is a great intention and we appreciate that. However, we with Parkinson's understand that it's very important to get the right dose at the right time every time. And so, if you're waiting for a long time to see a doctor, that could lead to missed doses. So, it's important to bring your medications there with you. And I'd just like to add that that's not to say that the EMS crews treating you are not very knowledgeable or qualified and experienced. However, unfortunately, not all EMS training is the same, and some have very little that is specific to Parkinson's disease, especially when we're looking at that non motor point of view. So I would just like to encourage you to make sure that you advocate for yourself, you advocate for your Parkinson's disease, because you are the expert in that. And that's how we will get the best outcome is working with that. All right, so thank you so much for listening to my presentation, and I will pass it back off to Krista.
Thank you, Ruth. I know that this is helpful information and could seem difficult to digest when we're not in the moment, right? So we think of the emergency response that the body has, what happens to the nervous system when we are in fight mode, right? Connecting and making sure that we are receiving the services that we need and taking a breath and moving through it in with a more clear-minded space. So thank you for offering us some tangible tips that we can apply to an emergency situation. I'll invite Dr. Fernando to join us for our question and answer session. I will proactively communicate that we have had an abundance of questions and want to be transparent that we do not have the time to address all of our questions, and we will get to as many as we possibly can. In the spirit of communicating about emergency situations and psychosis, Dr. Fernando, I will pass this question to you, and maybe Ruth, you can elaborate from your perspective. When, say, my partner with Parkinson's disease, I'm observing is having hallucinations, delusions, some form of psychosis, how do I communicate this concern with my partner, and when or how do I communicate it with their healthcare provider?
Yeah, I think the most important thing is to really speak about the phenomenon as a symptom of Parkinson's disease. And I know that seems really obvious, but when I do various neuropsychological evaluations, it's not uncommon for people to kind of incorporate their perceived performance into their identity. So in other words, sometimes people say comments like, gosh, I feel stupid, or I feel crazy, right? And which is just not true, you know, and so really pointing out that this is the disease, not you, is I think is an important foundation for communicating about a very difficult topic, right? And I think if you again you create that environment of safety for people to freely communicate those issues, it's just much more easier to talk about it in a clinical evaluation as well.
Thank you, Dr. Fernando. I appreciate you giving us the foundation of speaking to our loved one as a human, as a person, and not the disease. It's really important as humans ourselves to feel seen, feel heard in a gentle way, especially on a subject like this. Ruth,
Absolutely.
any more to add to that topic of communicating with your loved one?
I'd just like to echo everything Dr. Fernando said. That's exactly the way you want to approach that. And I think that everyone here is starting with that great foundation by educating yourselves on the disease and on psychosis and things that can occur. That's the first step into opening that open communication and creating a safe space.
Thank you, Ruth.
Krista, I would also add, again, in the spirit of communication, these are kind of more dialogue points than anything else, and it applies to any topic really. But even the way we phrase things and saying, "Hey, I'm concerned about you. I feel that there's something going on here that I'm just concerned about," rather than saying you statements like, "You are seeing something that's not there," or "You are behaving in such and such a way," right? Which is not only stigmatizing, but I think it helps, it puts people on the spot in a very uncomfortable way. So I think that it's just that general spirit of communication and safety that allows us to really broach some very difficult topics for patients with Parkinson's.
Yeah, and immediately when you use language that is directive and accusatory, what happens to our bodies? We become defensive and we want to protect ourselves versus having a dialogue. So I thank you for coming, giving examples of how we can have a conversation versus a lecture or just kind of derogatory. You've done it this way. How can it be a collaborative discussion? There's a question that came up from James that I feel is extremely important to address when we were speaking about emergencies in light of psychosis episodes. And he asks about anesthesia. So can PD psychosis be triggered by anesthesia? can medications or anesthesia given during a hospital visit trigger psychosis?
Well, I would maybe start by saying I'm not a medical doctor. I'm a different kind, but just having some general awareness about this. The short answer is yes, because anesthesia essentially what it does is it turns the front part of your brain off, right, and kind of puts you into this deep sleep. And so, unfortunately, we see folks who come out of anesthesia, especially long procedures and surgeries, they might awaken in somewhat of a confused state. And so we might see patients essentially manifest with delirium, right? And for folks with Parkinson's, who are already kind of cognitively vulnerable, we might see the delirium manifest as a result of anesthesia medication. So there's no really good way to predict whether this will happen, right? I mean, sometimes you just need anesthesia, but I think if there's a history of coming out of anesthesia confused, or just not alert, or just having difficulty returning to baseline, that's just something that we need to kind of proactively talk to our clinicians and surgeons about, so that we can minimize that as much as possible. Maybe even consider different types of anesthesia moving forward.
Thank you, Dr. Fernando. And the Parkinson's Foundation's Hospital Safety Guide does outline the types of anesthesia that are safe for people with Parkinson's disease to use and those that are not safe. And that link has been offered in the chat. Ruth, as we come to a close, I'm finding a question from one of our care partners here and thinking about words to use when we are communicating with EMS. You've dialed 911. Can you just reiterate, re-highlight, readdress what is the most effective critical information we need to communicate with EMS when we're on the hotline?
Yeah, so I think that it does very much depend on each situation and the exact reason that has triggered you to call 911. But I would just reiterate that to make it as simple as possible, because not all call takers have an extensive knowledge of Parkinson's disease. You probably have a lot more as a caregiver. And so to make it as simple as possible, and then once a crew arrives and you can talk to them face to face, that's when you want to give a little bit more of those detailed information on the Parkinson's psychosis and on exactly what's happening. So I would say stick to the simple reason for calling, whether that's delirium, whether that's a fall or injury or aggression. Using those terms and those words will trigger the right response.
Thank you, Ruth. And Dr. Fernando, I have one more question for you that seems to be a theme that keeps coming up in our Q&A pool. How to manage agreeing with visual hallucinations. So some examples is there a person with Parkinson's saying, please take the dog out for a walk. There is no dog. Or what are we having for our picnic for the party on the patio when there is no party on the patio? So could you offer some suggestions on how to agree with visual hallucinations that are more complicated?
Yeah. So I mean, in the example that I gave, I think I think I mentioned a dog kind of being in the environmental space. It's pretty easy to say then, like, well, I'll take the dog out, no worries. Or the dog's not bothering anyone. They're just sitting there, right? Again, because there's no insight into that particular visual hallucination, it's not really helpful to say, like, hey, there's no dog there, because that person's still going to say, like, no, there's a dog there, right? And that's the whole critical piece of insight. I think for one of the more complicated scenarios, like the patio on the party or a group of people kind of speaking, that one's a little bit more challenging, because you don't want to necessarily just say, like, oh yeah, there's a bunch of people out on the patio, right? And that's where maybe the tool of distraction kind of helps, and you kind of deviate to something else, or like, hey, we have a medical appointment today. Who was the doctor we're going to meet with today? Or, oh, hey, we have a grandchild's birthday or something, like to kind of try and see if you can distract that person a little bit. I think there's, and I do want to speak to folks who still feel frustrated because some of these tools that we're giving don't always work, right? And that's just kind of the tough part of this disease, and really any disease. I remember my second patient that I ever met. He had something called Capgras syndrome, and essentially he did not see his wife. He thought it was an imposter, right? And it was such a battle that they ended up having to deboard, get off a plane for their intended vacation, and they were not able to do that, which is sad, right? And I think there's some times where you use the tools in your toolkit as best as you can, and for the most part, I think these are tried and true, and they can help, but they doesn't always fix the problem, right? And so I want to just empathize and sympathize with a lot of those folks out there who've tried a lot of these things, and maybe it just didn't give the intended results.
Thank you for your supportive words, Dr. Fernando. We have gone over time, so I just want to respect everyone's time and expectations here and invite Ruth if you have any final closing remarks you'd like to share with our community before I jump into closing slides.
I would just like to say thank you again for listening. And the main point that I can say to take away is just keep advocating for yourself. And it's all a team effort. So that's great that you're here educating yourselves.
Thank you, Ruth. And Dr. Fernando, any final words?
In the same vein, I think knowledge is power, right? And I think, Ruth, you did an excellent job of pointing out that sometimes as caregivers, we're armed with a lot more knowledge about Parkinson's disease than other folks are, right? We can't expect everyone to know about Parkinson's, right? That's the goal. But that's why we do what we're doing today, to educate the community and make people more aware, so that we can be in a position to better support individuals in our family or our social network or even our community who are struggling with some of these various symptoms.
Thank you, Ruth, and thank you, Dr. Fernando, for your time and your knowledge for today's Wellness Wednesday, and a sincere, abundant amount of gratitude for those of you who continue to show up and learn more about the intimate topics that might be influencing your life, living and impacted by Parkinson's disease. I want to acknowledge that we did have a significant response to our QA session today. And it's unfortunate that we just weren't able to get to them all. So please, if you had a question that was not answered, do not hesitate to reach out to our helpline. The number's on the screen, 1-800-4PD-INFO. You can also email us at helpline@parkinson.org and visit our extensive resources, free resources at parkinson.org. And before you go, as we end the webinar, the Zoom screen will prompt a survey. Our programming is fueled by your feedback. I am deep in planning for our calendar year 2025 programming and take your words written and bubbled in very seriously. So please take some time to respond to that evaluation so that the foundation is able to provide programs that you are hoping to learn more through. And again, want to thank everyone who attended today, Dr. Fernando, Ruth, and the team behind the screen supporting the production. And thank you so much. Be well until I see you again.